Hello and welcome back. This will be part 3.1 in an approach to chest pain. I'll be discussing imaging in the diagnosis of pleuritic chest pain. Pleuritic chest pain, as we've discussed in the previous video in this series, can be due to a pneumothorax, it can be due to exudative pleural effusions and pleuritis, and it can be due to hydro-pneumothorax. So in this video, we'll talk about the notable gravity dependence of pneumothorax on imaging and how that influences imaging findings. We'll talk about the imaging appearance of a pneumothorax on a posterior anterior radiograph. We'll talk about mimics of pneumothoraces. Then we'll extend our understanding to radiographs when a patient is not in erect position. So this will include patients in lateral positions, patients in supine position. We'll go ahead and talk about pneumomediastinum. As I discussed in the previous video, clinically a pneumomediastinum usually does not present with chest pain, but it can closely mimic pneumothorax on imaging. So it is something that you need to know about when you're thinking about pneumothorax, and actually can co-occur with a pneumothorax. As I've discussed in the previous video, a secondary spontaneous pneumothorax and a secondary spontaneous pneumomediastinum share the underlying causes almost exactly, except for the addition of esophageal pathology and tracheal pathology, which typically naturally can result in pneumomediastinum, but not normally in a pneumothorax. So they can co-occur. So we'll talk about the Spinnaker sail sign, the Neckleria V sign. We'll talk about the double bronchial wall sign, the tubular artery sign, and then we'll talk about the continuous diaphragm sign in pneumomediastinum. Differentiate this from something called the double diaphragm sign, which is not seen in pneumomediastinum, but is rather a finding of pneumothorax in a non-erect patient. Hydro-pneumothorax will be the last thing that we'll come to, and that is relatively easy to diagnose on imaging. So again, I will not be discussing pleural effusions in this video. That will be the topic of one video from now in this series, primarily because the imaging findings are very different. However, as I've discussed, a pneumothorax and a pleuritis can have the same clinical findings. That is the same type of chest pain. Actually, once the patient develops the effusion that would secondarily develop, the pain decreases as the parietal and visceral pleura separate. So this is your pleural space with the lung inside. Air being lighter than fluid rises to the least dependent portion of the pleural space. The normal pleural space contains about 0.1 to 0.2 ml per kilogram body weight of fluid. So for a 70 kg adult, that would be around 7 to 14 ml. That fluid has a specific gravity of 1, and air being air rises in the opposite direction to the top of the pleural space when it is present in the pleural space. So because of that, you end up getting a pleural air accumulation here on top, as long as the patient is erect. On the other hand, when the patient is, say, supine or in a lateral position, that is a non-erect position, the air still accumulates in the top of the lung. That would be here. This is a normal erect PA view on the right side. On the radiograph that is shown in the middle, that is the inspiratory fill, we do not see any apparent pneumothorax. Now, how do I know this is an inspiratory fill? It's because the number of posterior ribs and anterior ribs that are visible. That would be 1, 2, 3, 4, 5, 6, 7, 8, and 9. Okay, so it's almost inspiratory. You'd require typically 10 posterior ribs to call it a inspiratory radiograph. Similarly, if you count the number of anterior ribs, you will find that there are 5. So there is 1, 2, 3, 4, 5, and almost 6. So because of that, this is almost an inspiratory radiograph. The reason why probably the patient was not able to inspire properly was because they have pain on the right side. Either way, the air is not particularly visible in this particular radiograph, but on the radiograph on the left of the screen, we find that there is a very clear hyperlucent area around the lung, which I've shaded in blue. A pneumothorax becomes much more visible on an expiratory film, and this is one of the indications we're asking for a expiratory film. The thing is, with pneumothoraces, the most important thing is to not overcall pneumothoraces, because as I've discussed, in a medicine patient or a patient admitted under internal medicine or any subspecialty of internal medicine, unless they have undergone a procedure or they have COPD, it is very unlikely that they would have developed a pneumothorax. So there are some normal imaging mimics of pneumothorax that we need to consider. On the right of the screen, I have a pneumothorax, the same that I had shown in the previous slide. On the left of the screen, actually, I have multiple lines that I have highlighted using red. So the red line here appears could be a pneumothorax, but the important thing is that the top and bottom, that is the uppermost end and the lowermost end of the line, do not end at the pleural margin. They don't end here. That would be very odd for a pneumothorax. The other thing that you find is that on the left side, there are multiple lines, not just one line. And one of those lines is actually crossing the diaphragm itself. So a pleural margin cannot cross the diaphragm because the pleural margin is the margin of the visceral pleura, of the lung, which naturally will stay within the chest cavity. These two things suggest that this is actually a skin fold. And how do we get a skin fold? This is basically the result of patient getting an AP view X-ray. And naturally, when you take a AP view X-ray, you put the X-ray cartridge behind the patient. And when the patient is supine or is unable to sit up, and the film is placed behind the patient, there are folds of skin that form. So as I've just said, those folds of skin tend to either not reach the ends of the pleural silhouette that you would expect them to reach, or there'll be multiple folds. So naturally, you cannot have multiple pleural margins. And the other thing is that unlike in the case of a actual pneumothorax, where pulmonary vascular markings stop at a particular line, here pulmonary vascular markings actually continue across those lines. So naturally, that is not a pneumothorax. And if you're lucky, you might see the line crossing one of the things that a pleural silhouette cannot cross. So if it crosses the diaphragm, naturally it is not the edge of the visceral pleural. The other two things that you need to see in a pleural fluid are in a pleural fold are, or rather in a skin fold are. One is that because there is folded skin on either side of the fold, the radio density on either side increases compared to normal lung. The other thing is that, as I said, pulmonary parenchymal lines do not cross the fold in case of a pneumothorax, or they do not cross the line in case of a pneumothorax, whereas in case of a pleural fold, they naturally would. Now, at times, normal anatomical findings can mimic a pneumothorax. This includes the medial border of the arm or the scapula. This naturally will occur if a PA film is not taken properly and the patient's scapula has not been externally rotated properly. So, whenever anybody gets a PA view of radiograph taken, they are asked to fold something like this, and then the scapula tends to externally rotate, and that may not happen adequately in some people. The other thing is pleural fat, but pleural fat is typically present on both sides of the radiograph. And if you're lucky, you may find an old radiograph finding the same pleural fat on previous radiographs that has not changed shape, size, or location. Some abnormal chest anatomy findings that can at times also mimic a pneumothorax include pulmonary bullae, calcified pleural plaques, but they tend to be hyperdense than what you would expect, and pneumomediastinum and pneumopericardium. So we'll be talking about pneumomediastinum in the upcoming slides in this particular screencast. The diagnosis of pneumothorax in a patient with a non-erect posture is actually the most common clinical scenario that arises in when suspecting a pneumothorax, because often the patient is either critically ill or the patient has pain. Radiograph has been taken in a hurry. So because of that, we need to understand what happens when the patient's position changes. So as I said, the air ascends to the least dependent portion of the pleural cavity. In this particular case, the patient is in a left lateral position, and you can see that there is a clear pneumothorax that is tending along the right lateral margin of the lung and extending into the right costophrenic space. So it's moving in here. This is actually called the deep sulcus sign. Normally, the end of the visceral pleura is two rib spaces above the end of the parietal pleura. So you would expect the pleural space to actually end up around here. But what you find here is that there is significant increase in the depth of the pleural space or the costophrenic angle, and that is called the deep sulcus sign. The lateral band of hypolucency and deep sulcus sign is seen in a patient with a right-sided pneumothorax, which is most apparent with the patient in the left lateral position, because that causes the air to rise to the least dependent position, that being the right side of the right pleural cavity. Here we find something very interesting. There is a tag of pericardial fat, which is normally not visible on a chest CT or a radiograph because the lungs compress against the cardium. Here, what has happened is, however, because of a pneumothorax, now the pericardial fat is free to hang into the space that is formed. Parietal pericardial fat appears to hang into the pneumothorax on the left side of the CT, and this gives the left cardiac border a quote unquote lumpy appearance on a AP radiograph. So this is what we call the pericardial fat tag sign. Coming to a pneumomediastinum. In pneumomediastinum, we have a few named findings which I'd like to highlight. The first is the mediastinum being continuous with the subcutaneous space of the neck. The air can dissect into the subcutaneous space of the neck, resulting in a subcutaneous emphysema. And that has a characteristic appearance which looks like the leaf of a ginkgo tree. So this is called the ginkgo leaf appearance, which I've highlighted it yellow. In the second radiograph, you can find a prominent triangular structure on the right side of the hemithorax and on the left as well. On the left, it is this. So this is what is known as the spinnaker sail sign. This is because it resembles the sail of a particular boat that is called a spinnaker sail. So this would be the boat and this would be the sail. The spinnaker sail sign is distinct from something called the thymic sail sign, which actually denotes the normal appearance of the thymus on a neonatal chest radiograph. There are two more findings in pneumomediastinum that we need to talk about. In the first radiograph on the left of the screen, we have the Niclerio V sign, which is a line that is formed between the left margin of the vertebral body and the silhouette of the diaphragm, which is visible when there is air within the pneumomediastinum. On the right side, we have what is known as the double bronchial wall sign. So what happens is that there is air within the mediastinum that therefore results in air being present both outside and inside the tracheal wall or the bronchial wall. So there is air both inside and outside. That makes the wall more visible, and that is what is called the double bronchial wall sign. The third is what is called the tubular artery sign, which is air within the mediastinum making the artery, that is the aorta in this case, and one of its branches visible on a AP radiograph. Once I remove the markings, you can see that it becomes very obvious. The fifth sign that we need to talk about is the continuous diaphragm sign, which represents air in either the mediastinum or below the diaphragm. Normally, the dome of the diaphragm and the heart are right next to each other. It cannot be differentiated from each other on a radiograph. But here, the presence of air between them allows us to differentiate them from each other. This is called the continuous diaphragm sign in Pneumomediastinum. Then there is also something called the double diaphragm sign that is present in a supine patient with a pneumothorax. The double diaphragm sign is not a finding of pneumomediastinum. So here what is happening is that the air within the fundus of the stomach on one side and air within the left hemithorax is making the upper and lower silhouettes of the diaphragm more apparent. But these sound similar, they are not the same finding, and they represent completely different pathologies. Now, coming to hydropneumothorax, it is relatively easy to understand. Fluid is present in the pleural cavity and air is present. So what ends up happening is that the normal meniscus that the fluid within the pleural space forms gets flattened, and you get a flattened silhouette at the interface between air and fluid. So it is very obvious in this particular case. So this is what we call this is what the imaging of a hydropneumothorax is like on a EP radiograph. In this particular video, we covered the following topics. We talked about pneumothorax and its gravity dependence on imaging. We've talked about the appearance of a pneumothorax on posterior and anterior radiographs, the mimics of a pneumothorax, both physiological and pathological. We've talked about the appearance of a pneumothorax on radiographs when the patient is no erect, that is, patients when they are in lateral position as well as in supine position. We've then talked about Pneumomediastinum. I've talked about some named signs, which are obvious questions in memory-based MCQs. So that includes the Spinnaker sail sign, the Necklario V sign, the double bronchial wall sign, tubular artery sign, then the continuous diaphragm sign, which we differentiated from the double diaphragm sign. The double diaphragm sign being a finding of pneumothorax in a patient in supine position rather than that of pneumomediastinum. And then we briefly talked about hydropneumothorax on imaging. In the next video in this series, I'll be talking about an approach to cystic lung disease, which actually can present with a pneumothorax, but usually is an incidental finding, or it is related to the cause of the cyst formation. But radiologically, they tend to come in the same diagnostic evaluation as pneumothorax, and this is the best place to incorporate it into a clinically oriented discussion.